Hello, this is Robert Lee, and this is a brief video on oligometastatic prostate cancer. The agenda: first to define oligometastatic disease and prostate cancer, randomized trials to treat the primary, we'll go through those, and then finally the randomized trials to treat metastasis. So the definition of oligometastatic disease is not yet defined. The simplest way to do it is just to count the number of metastatic sites that you see. This is taken from a secondary analysis of a randomized trial, the TROG trial, looking at ADT and radiation. These are men who develop bone metastasis in follow-up on routine bone scans. And you can see that if you have a single bone met, you do much better than if you have 2 to 3, and better still than if you have more than 3 bone met. So there's clearly a spectrum of disease. Oligo is from the Greek oligo, which means few or small. The problem is we can't really decide on how few or how small. We do have 2 randomized trials that address the question of do we treat the primary in the setting of metastatic disease, the HORAD trial and the STAMPEDE trial. This is the schema of the HORAD trial. Metastatic disease in bone from prostate cancer. Sample size is 400. Overall survival is the endpoint. Standard arm is androgen deprivation therapy alone. Experimental arm is androgen deprivation therapy plus radiotherapy to the prostate. So it's local radiotherapy, not treating the metastasis. Primary endpoint is overall survival. Here are the initial results. Very little to see here. It's hard to make a justification that the addition of radiation adds anything. The authors did provide a subgroup analysis, a forest plot, and if you look at the population of folks with less than 5 metastasis, the hazard ratio estimate is 0.68, which did not reach statistical significance, and this is hypothesis generating, but it suggests that there may be benefit in that population. But with 400 patients, it'd be very difficult to make that statistically significant. A much larger study is the STAMPEDE study. 2,000 patients, metastatic prostate cancer, receiving the standard of care, which was largely androgen deprivation therapy, or the standard of care plus radiation, in this case, to the primary site, published 2 years ago in Lancet. For the entire group, here's the overall survival. Again, difficult to see much of anything here. The authors did provide a pre-specified subgroup analysis according to metastatic burden, which again was pre-specified. And in those patients who were determined to have a low burden of metastatic disease, there seemed to be an effect. The interaction p-value is as you see there. And the hazard ratio is remarkably similar to what was seen in the HORAD study. The reason that we now have a p-value is probably related to the fact that we have more events and therefore more power. If you look at the low metastatic burden subgroup and overall survival, radiotherapy seemed to improve overall survival. Low metastatic burden in this setting was less than 4 bone metastasis with no evidence of visceral metastases. Comparing and contrasting these 2 studies, very similar design. The HORAD is much smaller though, and a much more advanced group of patients. You see the median PSA of 142 on HORAD, and a third of those patients were felt to be oligometastatic disease. STAMPEDE, much bigger, few more patients with oligometastatic disease, which is probably why you see the difference. I conclude from these studies that we should treat the primary with radiotherapy. How about the metastasis? Well, we have 3 different studies looking at do we treat the metastasis: SABRE, COMET, STOMP, and ORIOLE. So this is SABRE COMET, which is a interesting study. Basically, you're required to have a controlled primary and 1 to 5 METs found on any form of imaging. So it's a very broad eligibility criteria. It's a 2-to-1 randomization such that patients, or twice as likely to be randomized to the SBRT arm. The standard arm is standard of care, which is systemic chemotherapy or androgen deprivation, whatever the primary site dictates. And the experimental arm is to use SBRT to treat all of the metastatic disease. Here are the sites of the primary tumor. You can see it's quite varied. There's breast cancer, colorectal cancer, lung cancer, prostate cancer, and about a third of the patients had something else. This is a total of 16 prostate cancer patients in this study. It's very difficult to generalize any results from a population of 16 patients. Here's the entire population. Again, randomization is 2-to-1. Now, this was what they call a phase 2 screening study, and in their view, so long as they get a p-value of less than 0.2, then they should go forward with the phase 3. Here's the progression-free survival that we see. A p equals 0.09. The hazard ratio is 0.57. Hasten to point out that there were 3 deaths in the SABRE arm, so there is some toxicity associated with treating metastatic disease. The next study is the STOMP study, which is only prostate cancer, and these are men who have 1 to 3 metastases on choline PET. This is 62 patients, 1-to-1 randomization. The control arm is observation, so these are men with metastatic disease in whom nothing further is done versus irradiating the metastatic sites with SBRT. The primary endpoint is ADT-free survival, which is shown here. You can see that if you observe metastatic disease, it continues to grow, which is the blue line. The yellow line suggests that perhaps you can delay ADT for a few months if you use SBRT. Again, no survival advantage. This is ADT-free survival, which is, I have a problem with that endpoint. It's quite subjective. Finally, the Oriole study, which is patients with prostate cancer, 1 to 3 Mets on conventional imaging, CT, the abdomen, pelvis, and bone scan, 54 patients, 2-to-1 randomization. The control arm, again, is observation. So these are men with metastatic disease in whom the standard arm is to do nothing. 2-to-1 randomization, SBRT to metastatic disease. Progression-free survival favored those patients in whom you actually treated the disease. This really shouldn't come as any surprise that treatment of known disease is better than no treatment when using progression-free survival as the endpoint. Putting this all together, from these 3 studies, there's no suggestion of an overall survival advantage. All of these use some sort of progression-free survival endpoint, which is very problematic in my view, especially when you're comparing treatment to no treatment. Fewer than 200 patients have been reported. There are no phase 3 trials that have yet to be reported. Some are ongoing. And just to highlight, I don't think progression-free survival is a very good endpoint, especially when you're comparing it to doing nothing at all. So, do we treat the metastasis? In my view, the answer is not yet. Now, just to give you an example of studies going forward, this is Bridget Kuhn's study, which is a proposal now in the NRG. We'll go to the GU steering committee soon. Basically, looks at men who are bone scan negative but PET positive, up to 3 Mets, and they are hormone naive. They basically, the randomization is everyone gets SBRT to the metastasis. One group gets darolutamide up front at the beginning, and the other uses darolutamide at the time of PSA progression. Here are the resources. Thank you.